hello everyone. So can you see my screen?
Yeah.
Okay.
Yeah.
Yes, of course.
So let me make it a full screen.
It's okay, sir. It's okay. You should
Okay.
you should give co-host Tolga me to change the screen.
Okay, good. Okay, is it in full screen now? So I will start. Okay. Hello everyone. Good morning, good afternoon, and good evening, depending on where you are. I'm Charlie, International Marketing Manager from Wisonic Medical. So welcome to join this global webinar of Wisonic Dandelion College. As you know, Dandelion College is a platform for sharing and learning more about latest research and knowledge of regional anesthesia, pain management, and intensive care. So today is our great honor to invite Dr. Maria Fajardo and Dr. Tolga Ergönenç to be our speaker for this webinar series. The topic today is upper extremity sonal anatomy and life-saving blocks for chronic pain. So firstly, I would like to introduce our speaker, Dr. Maria Fajardo. So he is a professor of anesthesiology and regional anesthesia at Mostoles University Hospital in Madrid, Spain, where he served as a chair of education, regional anesthesia, ultrasound interventional procedures, and program director of the Regional Anesthesia Fellowship. Dr. Maria Fajardo is the chair of Ultra Dissection Group. Dr. Fajardo is the founder of MOMARC, so that stands for Madrid Morphologic Research Center. So he worked as an associate professor at anatomy in Autonomous University Medicine School. So Dr. Mario Fajardo has dedicated his career to curriculum development and the implementation of the science. So his research interests involve understanding the best methods to teach applied anatomy and ultrasound. His education research has been within accessing curriculum development and application spin-up learning system and Anatomy 5.0. In the clinical domain, he has focused on sonal anatomy to develop and implement new approaches for knee, shoulder, and breast surgery, and implement best practice of post-operative pain control. His studies recently involve understanding how to use vagus nerve stimulation as part of a multimodal analgesia. So let's move on to Dr. Tolga Ergönenç. He's an anesthesiologist who is working on ultrasound-guided intervention and musculoskeletal sonal anatomy. Dr. Ergönenç graduated from the Wuladong University Faculty of Medicine in 2000 and was awarded a medical doctor. He became a specialist in anesthesia and intensive care in 2006. So he joined Sakayan University Education and Research Hospital in 2006. He is currently head of Akayazi Pain Center and Traditional and Complementary Medicine Unit. He has adopted the multimodal approach to pain management, which includes pharmacotherapy, therapeutic, and diagnostic interventions, and requires close cooperation with physiologists and psychiatrists, orthopedic surgeons, and neurosurgeons. He has been invited to many international pain cadaver workshops on ultrasound-guided interventions and delivered several international meetings. So let's welcome Dr. Mario Fajardo to share his part of the lecture. So let's welcome.
Good morning, everyone. Good afternoon, China. It's a pleasure for me to be in this webinars. Really, the anatomy is the base of real anesthesia. I think the people should know well the anatomy, the patient, and the surgery. Now, let me share my screen. This is one of the cadaver dissection in our lab. Really, I would like to say thank you to the people to donate the body for the science, because this allows us to practice this dissection and try to spread the knowledge of anatomy around the world. This is the master class of the upper limb. I would like to show you only 3 blocks necessary to be success in real anesthesia. But when I teach real anesthesia, a lot of students want to only make a puncture, but do keep in your mind several things previous block. First, this patient have a diaphragm palsy, underwent shoulder surgery. It depends on what side of surgery is, your strategy change. This patient suffered melanoma and have shoulder pain, chronic shoulder pain, and one of the most common techniques is the block of suprascapular nerve. And now you should change because the patient in the side of the needle puncture have a cancer. And the other patient suffered a big tumor in the axilla. If this patient go to the surgery with hand fractures or forearm fracture, it's impossible to practice axillary block. This patient is obese, have a short neck, big hematoma, suffer humerus fractures. And now it's difficult to find a nice anatomy. For the reason, you always try to integrate the patient, your ability, the ability of surgeon. This patient suffer as underwent is traffic accident. After traffic accident, the people come to our hospital to the scapula fracture, and then the patient suffer neck fracture too, and it's difficult to block the interscalene or whatever to reduce the pain. This is one children with hand damage, and what do you do with this patient? It's axillary, supra, infra. This patient suffer anticoagulation. Take anticoagulation and have a big hematoma. What do? The patient suffer have a lot of vessel around the brachial plexus, ascending cervical artery, transverse cervical artery, dorsoscapular artery, suprascapular artery, inferior thyroid artery, vertebral artery, carotid artery, subclavian artery. All of these aspects you should keep in your mind previous block. If you choose only one technique for all part of the upper limb, this approach is supraclavicular block. Normally, we start learning from the interscalene. After that, supra, axillar, peripheral net block, and at the end, infra. but the supraclavicular block is the most strong block in the upper limb. You practice shoulder surgery, humeral fractures, elbow, hand, forearm, all procedure in the upper limb. This is my cadaver dissection. Is the new, this picture will be in our book. The brachial plexus is C5, C6, become upper limb, upper trunk, C7, middle trunk, C8, T1, lower trunk. Upper trunk, middle trunk, lateral cord. Inferior trunk, medial cord. All posterior branches, posterior cord. From posterior cord, axillary, nerve, and radial nerve. Lateral cord, musculocutaneous, and one part is median nerves. Medial cord, ulnar, and cutaneous of forearm or forearm. And for the reason, all perivascular or periclavicular block is very strong, supra and infra. But the infra, the people have afraid with the pleura puncture. For the reason, when I teach to my resident, first teaching supraclavicular approach instead interscalene block. What is the indication? Hand fracture, shoulder fracture, hand amputation, traffic, and then I have to perform this block. How can I do it? All reunion anesthesia procedure should be easy. This is the proof position. You keep in your mind, what do you see when you place the proof in a specific area? This is the ultra dissection. This is the name of our school, ultrasound and dissection. This is what you see when you place the proof in the supraclavicular area. Imagine the sun block. The brachial plexus is closed in the supraclavicular area. For the reason, this is the strong block, an easy block, quick to start, and it's nice for beginners. This image is from one of the best ultrasound page, neuroaction. This is the image of the supraclavicular plexus. You identify ribs, subclavian artery. In the upper part, laterally to the artery, you find the brachial plexus. And hidden to the artery, below to the artery, you find the lower trunk. The lower trunk, T1. And for the reason, this technique is very interesting. When you practice reunion anesthesia or supraclavicular block for shoulder surgery, you should block the upper trunk. The upper trunk is from C5 and C6. All nerve that supply the shoulder become from upper trunk. If you practice reunion anesthesia or supraclavicular block for elbow or hand, you should block the ulnar nerve. Why? Because the ulnar nerve supply the 80% of intrinsic muscles of the hands. If you place the needle tip in the corner pocket for shoulder surgery, probably you fail, because the supraclavicular nerve is the first anterior collateral branch that leaves from the upper trunk, early leaf. For the reason, when you practice supraclavicular block for shoulder, you only block the upper trunk. For elbow hands, you should place the needle tip posterior to the artery to block the corner pocket, to block the ulnar nerve. This is the diagram that I talked to you. The ulnar nerve is posterior, around 5 to 6 to the artery. This is the real patient. You see the ribs, you see the artery, you see the LT is lower trunk, MT middle trunk, UT upper trunk. SCN is the supraclavicular nerve. Supraclavicular nerve is leave early. And if you have in your mind this image, the success is okay. You will be success in all procedures. This is the approach. Normally depend on patient, is obese patient, sumo fighter, big muscles. Normally I use sitting position or lateral position. My approach is from posterior to anterior, better than lateral to medial, because you can have a free way to insert the needle like this. Look, the needle. This is the cluster block. This is surgery of or the elbow. And now this is the lower trunk here. This is the procedure. How many volume can I use? I usually use 15 to 20 cc of solution, because it's not necessary more. This is the simulation of cadaver. It's the same video that you see. You see the supraclavicular nerve is this one. And this is the upper trunk. You could see the long thoracic nerve here. And this is the chief of the brachial plexus. And this is the video, the same like cadavers. This patient suffered middle humeral fractures. The surgery introduced the nail into the arm. And look at this. This is the clavicle. This is the brachial plexus. This is like an onion signs or garlic. This is the spread the solution around the brachial plexus. You see the artery, the subclavian artery. This is the supraclavicular nerve. If you see, look, the local anesthetic go up, but the supra leave very earlier. If you place the needle tip posterior to the artery, you should wait a lot of time to block the supra, and probably for shoulder surgery could not be. Because if you see the spread of solution, don't get it, the supra. What is the dose? The dose is 20 cc. Look, 20 cc this is the supra. You see now how the spread of solution up after place the needle tip in the corner pocket. This is the supra. But it's not necessary for shoulder surgery. Inject posterior to the artery. And now, this is the simulation of pleura puncture in supra. The T1 resting on pleura. Look at this. This is pleura, and this is T1. This is the artery. And when you place the proof in this direction, you see first artery, ribs, and pleura. Artery resting in the ribs and pleura, like a podium. Let's go to the interscalene. Interscalene, the only indication for this technique is shoulder surgery. Shoulder surgery and sometimes shoulder pain. If you want to rehabilitation, place a catheter, but only the main indication is shoulder surgery. The people, when I start to learn regional anesthesia, my professor say me, this is the basic block. Really is not the basic block. The interscalene is similar like a lumbar plexus block. It's the same. Embryologically, it's the same. But in my opinion, after 15 years of teaching regional anesthesia, the supra is better. It's more easy to learn for the beginners. These techniques, the interscalene is a nice techniques, absolutely. Yesterday I practiced two interscalene blocks. And it's not the best technique for learning because you have to keep in your mind several aspects of this technique. The interscalene block is easy, but sometimes could be dangerous. You find the brachial plexus between anterior scalene muscles and middle scalene muscles. This is the anatomy, this is the dissection. And you see the piano-phrenic nerves resting in the anterior scalene muscles, and the brachial plexus coming in and situated between two muscles, anterior and middle scalene muscles. This is the location of the anatomy of the brachial plexus. You can find both procedures, from medial to laterally or from supraclavicular approach to up. This is trachea. This is thyroid gland. This is carotid artery. This is jugular vein. Hey, look at this. Look at this. Vertebral artery, ascending cervical artery, dorsoscapular artery, transverse cervical artery come in. Look. Look here. And now, this is the anterior scalene muscles. This is the middle scalene muscles, and this is the brachial plexus. This is the position of the proof to see C5, C6, C7, T81. When you practice interscalene, you never see it. C8 and T1. And C7 is difficult. You normally see C5, anterior and posterior division of C6, but it's not necessary more for shoulder surgery, because shoulder surgery only need block C5 and C6. Look at this. This is the position, the lateral position of the patient. I start from medial to lateral, or from supraclavicular area to get the interscalene block space. This is the anatomy that you keep in your mind. Brachial plexus between anterior scalene muscle and middle scalene muscles. This is the anatomy in demonstration, the proof position. In yellow, this is the brachial plexus, the upper trunk. And this is the anatomy. This is the brachial plexus. This is the upper trunk, and this is the middle trunk, or C5, C6, and C7 here. This is the needle insertion. When you practice, when you're scanning and you see exactly the nice ultrasound image for interscalene, you should prepare your approaches: posterior, anterior, in plane, or out of plane. Normally the people use posterior approach. In other class, probably I teach it the anterior approach. Anterior approach is nice, but I don't know the level of all doctors in the webinars, and I think should be easy. The posterior approach is the most frequently, the most used, and it's not safe because you have several nerves, accessory nerves between elevator of the scapula and trapezius. posterior approach of PIPA to cool damage. In the middle of the middle scalene muscles, piercing the middle scalene muscles, you find long thoracic nerve and dorsoscapular nerves. Scanning previews show around prepare your strategy, because all procedures could be damaged. This is the approach. This is the cadaver, the ultra dissection pictures. The bracket plexus between anterior scalene muscle and middle scalene muscles, covering by omohyoid. The tendon of omohyoid is always in the interscalene growth. And bracket plexus. This is the procedures. If you see this image, this is the brachia, the cervical plexus. You see one image in this direction in the posterior part of the triangle of the neck, crossing the needle. This is the cervical plexus and accessory nerve. This is the upper trunk. Look at this. This is the dorsoscapular nerve. This is the dorsoscapular nerve. And here, the long thoracic nerve. This is my needle insertion. Only 10 cc is enough. Sometimes the people want to pass the needle. If you place the catheter, you can place the catheter. You can place the catheter. Pass the catheter and put back, or I will explain. And place the catheter. And the rate of infusion is 2 to 3 cc, no more 5. But the phrenic nerve is here. This is the middle scalene muscles and anterior scalene muscles. This is the bracket plexus. This is C5 and this is C6. Okay. This is that I talk. Upper trunk, middle trunk, C5 and C6. This is my coloring cadaver. We inject latex in the bracket plexus to see the anatomy like a book. This is the demonstration of interscalene in cadaver. This is the spread solution. The last one is the axillary block. Axillary block is like an interscalene. The people talk about the basic procedures. In my opinion, it's not good. It's not basic procedure. You should block 6 nerves, 4 final nerves and 2 cutaneous nerves, but it's easy. The image is this one. This is the latissimus dorsi, and you see the artery and around the nerves. This is the precision of the proof to try to find the radial nerve. This is the image of the cadavers. This is amazing, the amazing image of cadavers. This is the procedures, how to insert the needle. I prefer block first radial and ulnar, and at the end medial and musculocutaneous. This is the procedures, and I usually use 5 cc per nurse. And I hope you enjoy this short lectures, and very, very glad to have this lecture and work with Wisonic and Tolga.
Thank you so much for your excellent lecture from Dr. Maria Fajardo. So very, useful techniques, as you mentioned in your lecture, and there is among of beautiful pictures, cadaver pictures in there, very vivid, demonstrate which block you can get from where to where. So I can't say there is any person in the world can do any more better things than you, because you already done the best job, I think. So yeah, thank you so much. Thank you so much. So accordingly, I think let's welcome Dr. Tolga to have time for his lecture. So welcome.
Good morning, everyone, or good afternoon, or good night. Do you hear my voice clearly?
Yeah.
Is it okay?
Yeah.
Okay.
Yeah, perfect.
Let me a moment for sharing my screen, please. Please unshare your screen, Professor Mario. Please unshare your screen, and then I can share my screen. First, Professor Mario should unshare your screen.
Yeah.
Then I can share my screen after.
Okay. Okay.
All right.
Okay. Thank you.
Mm-hmm.
See my screen now? The Professor Mario
progress.
gives us an excellent lecture. The Professor Mario's lecture is very, very interesting, especially the cadaveric pictures and the cadaveric studies are excellent. I really always inspire and admire to Professor Maria's work. I always say these are real fresh cadaver, because the learning process of the ultrasonography, the cadaveric studies are very important, but you have to know, you have to be sure your cadaver is real fresh cadaver, tail cadaver. So you can work on easily to understanding the ultrasound guided everything. I would like to talk on ultrasound guided injection of the chronic shoulder pain. And I use many applications and platforms and books as a references for this presentation. This presentation, I prepared pro-positioning and some anatomic illustration and ultrasound image, commonly seen shoulder structures, especially these anatomic structures. And I would like to start with bicipital tendon. You know, biceps brachii has two heads, a long head and a short head. When we are talking about the interventional pain procedures and diagnostic ultrasound on pain of shoulder, we always mention the long head of the biceps. You can see clearly at this slide bicipital tendon and transverse ligament. This is another real cadaveric photo, and you can see in this slide greater tuberosity and the lesser tuberosity. When you put your transducer over the anterior window like this, the transducer beams are cuts or split the tissue like a knife. So you can see this anatomic structures easily. At this illustration, you can see the greater tuberosity and lesser tuberosity, and the intertuberosities groove. You can find easily along the head of the bicipital tendon. And the most superficial muscle is the deltoid muscle, which is under the skin. This is the sonogram of the anterior window of the shoulder. In this sonogram, you can see the long head of the biceps and the greater tuberosity and the lesser tuberosity and the subscapular subscapular tendon as well. This is the normal sonoanatomy of the anterior window. And this sonogram shows us the bicipital tendonitis. You can see the hyperechogenic fluid around the biceps tendon, and you may notice that irregularity of the tendon and abnormal echogenicity. You need to know the bicipital tendon sheath is connected with the glenohumeral joint. If you see the peritendinous effusion, but the biceps tendon shape and echogenicity are normal, this fluid may come from the glenohumeral joint. And in my daily practice, I prefer in-plane approach with medial to lateral side for the bicipital tendon sheath injection due to prevent the puncture to the anterior circumflex humeral artery. You don't want to puncture any healthy artery, vein, or any healthy nerve while you are doing your procedures. I use medial to lateral aspect in plane for the bicipital tendon sheath injection. When you turn your transducer 90 degrees, you can see the bicipital tendon in a long axis view. The sonogram shows us the long axis view of the bicipital tendon. And at this sonogram, you can see an amount of fluid and synovial thickening around at the row and the surrounding biceps tendon sheath. You can do your procedure with a long axis view and in-plane approach like this. If you see the synovial thickening and the fluid around the bicipital tendon, in the tendon sheath, you can think that the patient problem is the tenuous novitis or tendinopathy, but partial thickness and the full thickness tear is occur with this pathology. This is a spread of the local anesthetic or steroid agent or whatever you would like to inject into the sheath. Let's look at acromioclavicular joint. Acromioclavicular joint is the articulation between the clavicula and the scapula. When you put your transducer over the AC joint, the ultrasound beams split and cut through the tissue like a knife. So When we're gonna see this transducer position, sometimes we need to tilt transducer a little bit for the best view. You can see the AC joint. Put your transducer parallel to the joint, and you can see this sonogram clearly. You can see the clavicular and acromion, and the superficial ligament is the acromioclavicular ligament, and AC joint can be seen easily. In my daily practice, I usually perform my intra-articular AC joint injection in plane approach like this, but sometimes I prefer the out of plane approach, because when I perform scapular block or suprascapular nerve radiofrequency ablation, then I would like to do the AC joint injection at the posterior side of the patient. I prefer the out of plane approach like this. You need to know, while performing out of plane approach, you can see only the tip of the needle, not all the needle. You can see just tip of the needle. So out of plane approach is not easy for the beginners. And there are another important anatomic structures at the shoulder. These are bursa. You can find in the slide the subacromial bursa and the subdeltoid bursa, and the coracobrachial bursa, and the subcutaneous acromial bursa. The most important one is acromial subdeltoid bursa. When you put your transducer at the lateral window of the shoulder, a sonogram demonstrates the subacromial subdeltoid bursa. In normal condition, the bursa is essentially seen as potential space. You cannot see clearly this bursa. It's not easily to find, but the bursitis occur. We can see very thickening bursa and distending bursa with fluid. And the intrabursal injections of steroid, local anesthetic agent, or ozone can be performed with like this. You can do your procedure in plane approach that I use and prefer the subacromial subdeltoid bursa injection like this. In plane approach, it's very easy to perform. And when you turn your transducer 90 degrees and inject something into bursa with short axis, you can perform your procedure anterior to posterior in plane approach. Anterior to posterior in plane approach. And then let's see this slide. You can see the sonogram, the deltoid muscle, and the supraspinatus tendon, and the bursa. Maybe you can notice that the full thickness tears of supraspinatus tendon connect with glenohumeral joint to the subacromial subdeltoid bursa. Anterior to posterior approach. Let's see the glenohumeral joint. When excluding the superficial anatomic structures, the glenohumeral joint will appear. The glenohumeral joint, also known as a shoulder joint, articulates between the humerus and the scapula. It's ball and socket type joint. This is the posterior side of the glenohumeral joint. we are performing to glenohumeral joint injection at the posterior side. It's my preference in my daily practice. I usually use the intra-articular glenohumeral joint injection at the posterior side, and the best way of the injection is lateral to medial. We don't want to puncture the glenoid labrum. Always you have to choose shortest way while you are reaching your target for the interventional procedures with ultrasound guidance. You can see the humeral head here, and deltoid muscle is the superficial muscle, and the infraspinatus muscle and the tendon, and you can see the glenohumeral joint, and you can see the glenoid labrum. You don't want to puncture labrum. And okay, there is another anatomic structure. When you put your transducer over the anterior window of the shoulder like this, the subscapularis tendon can be seen easily. This is the long axis view of the tendon. The fibrillar pattern is seen along the tendon, which is inserts into the lesser tuberosity. And when you turn your transducer 90 degrees, you can see the short axis view of the subscapularis tendon. You can see the hyperechogenic fibers and the hypoechoic cleft due to interpose the muscle to the fiber among the tendon fibers. This is a normal sonanatomy of the tendon. This is not a pathology. You can perform your procedure in plane approach like this. And this is a short axis image of the central hypoechogenic subscapularis tendon defect. And another pathology, you can see easily partial tear of the subscapularis tendon. And the long axis view of the subscapularis tendon shows us the full thickness tear. And we can see the subscapularis tendon calcification on the sonogram. And another part of the shoulder, the transducer and the shoulder position, like this for seeing the supraspinatus tendon. This is a modified crest position, the best position for the easily recognized the supraspinatus tendon. This is the long view. This sonogram shows us the supraspinatus tendon and deltoid muscle, and you can see the perfect line of the articular cartilage. There is no irregularity on the bone, and there is no any osteophyte and the sonogram. And you can see the arrowhead indicates that the anisotropic artifacts, this is not a tear, this is a just artifact. You can perform your procedure in plane approach like this. And the short axis view of the supraspinatus tendon, you can see the subacromial, subdeltoid bursa, and you can see here bicipital tendon as well. And the perfect shape of the cartilage. And this sonogram demonstrates a short axis view of the partial thickness tear of the supraspinatus tendon and the long axis view of a full thickness supraspinatus tear here. You can find all shoulder pathologies easily with the ultrasonography, except intra-articular side of the long head of the biceps tendon. And the patient and proposition for evaluation to the infraspinatus tendon like this. This is a long axis scan of the infraspinatus tendon. You can see the greater tuberosity and infraspinatus tendon and the myotendinous junction here. You can find the posterior side of the posterior window of the shoulder for infraspinatus tendon. And this is longitudinal ultrasound shows us diffuse thickness and hypoechogenic infraspinatus tendon and multiple hypoechogenic structures. You can easily find the tendinosis, and there is a tear here in the infraspinatus tendon. You can see the thickness, diffuse thickness of tendon, and you can see easily the tear. Another important anatomic structures is suprascapular nerve, which Professor Mario mentioned, the suprascapular nerve. And suprascapular nerve, we know, mixed nerve, meaning that it provides both sensory and the motor supply for the suprascapular region. The suprascapular nerves provides 70% of the sensory innervation of the shoulder joint. So suprascapular nerve procedures have been reported to be effective in treatment acute and chronic shoulder pain. This is the sonogram of the suprascapular fossa. You can see the transverse scapular ligament here easily, and the other muscle, trapezius muscle, and the supraspinatus muscle here. And this is a suprascapular fossa here. The transducer position and the needle position should be like this: medial to lateral in plane approach. Let's look closer this area. You can see the artery, vein, and the nerve together at the supraspinous fossa. When you put your transducer above the spine of scapula, you can see the fossa and you can see the ligament easily. Put your needle tip under the ligament, but I advise you please use Doppler image for the finding artery here. And the last and most important, the new novel block, the shoulder anterior capsular block for shoulder pain. This is a novel block. Dr. Felice Galluccio and Professor Mario and our colleagues, Dr. AJ, find that block with all these faculties together. And you can find this article by scanning this QR barcode, and this paper published in Pain Physician. Suprascapular nerve, you know, 70% about the sensorial innervation, but other side is the 30% innervation from axillary nerve. And you can see in the slide why we need a novel shoulder block. And what did Dr. Felice Galluccio and colleagues find? You can read this article for study step by step. And this photo from study, which is performed on fresh cadaveric picture. Fresh cadaveric studies gives us the chance to find novel method for the relief, pain, and other lots of things. And what is the indication of shock block, especially acute pain, and you can use chronic shoulder pain relief for the relief for the shock block, and you can use the frozen shoulder and the post-traumatic acute pain and osteoarthritis of the pain, osteoarthritis of the shoulder. This is a chronic shoulder pain, and shoulder pain following the breast surgery or radiotherapy. You can combine with PAX block. And during the rehabilitation and the physiotherapy to speed up recovery to shoulder after the shoulder surgery. And first step is localize the humeral head and humeral head here, and the coracoid process with the arm slight internal rotation. As you can see here in this image, you can see the coracoid process and the humeral head, but we cannot see now clearly the subscapularis tendon. Then the external rotation, we can see the subscapularis tendon as well, and the myotendinous junction will expose. Then the next step, localize the perfectly over target, is put the patient with arm extension and rotation and abduction. And you can see this picture, the patient arm position. The first target is the interfacial space between the deep lamina of the deltoid muscle and the superficial of the subscapularis muscle. The second target is, you can see here, that this is a black line, is the pericapsular space between the myotendinous junction and the joint capsule. The first target here, interfacial space, and second target is the pericapsular space. You can perform your procedure like this long axis view. The first interfacial space and the second injection, the pericapsular space. And I would like to special thanks to my colleagues for this novel block. And thank you so much for your attention.
Thank you so much, Professor Tolga. You gave us a very impressive lecture on how the shoulder pain, how we tackle such kind of a pain in clinical scenarios, different clinical scenarios. You give us a lot of methods and ideas on how to do that. So thank you very much. So in here, I really appreciate Professor Mario Fajardo and also Professor Tolga Ergönenç. So thank you so much. I think the next session will be the Q&A section. And Professor Tolga will be the host for this session. And I think there will be several questions from our audience. So please, so let me leave time for you, okay?
Okay. There's lots of questions here, I see, and there's lots of thanks to Professor Mario and for lecture. And there is one question I say that from Turkey, and one colleague asked to Professor Mario, what is your what's your advice to us diaphragm sparing? It's mean a diaphragm sparing block for the upper extremity surgery. It's mean I think that the interscalene block for Professor Mario. What's your advice to our audience for the diaphragm motor sparing block while interscalene procedures?
But the people have afraid for diaphragm palsy, and when you are practice any interscalene block, you always keep in your mind the side of the block could be blocked. And previous to the procedure, you have an algorithm. The patient suffered idiopathic diaphragmal palsy. The patient have diaphragma hernia. The patient suffered thyroid surgery. The patient suffered carotid artery surgery, previous the shoulder surgery. The patient have pneumonia, pneumothorax, hydrothorax in the other side of the brachial plexus block, then, or the patient have the same sides of brachial plexus block. It's in different sides, in the opposite side. You always should practice peripheral block, so it block the axillary nerve, suprascapular nerve, pectoral nerves, and cervical plexus, or anterior approach of capsule to block the subscapulary nerves, axillary nerves, and complementation with the suprascapular nerve and supraclavicular nerves. Or block the upper trunk. If you reduce the volume, no more than 15 cc, probably you reduce the diaphragma palsy. And in my daily practice, I introduce the ultrasound lung evaluation previous the block. You place the proof in the contralateral side and evaluate the diaphragm. Is the diaphragm a movement? It's no problem when you block the site of the surgery. In healthy patient, if you have obese patient, COPD, previous trachea on thyroid surgery or carotid surgery, and the patient suffered palsy of the vocal cord, have tracheostomy, is this kind of patient you don't perform interscalene block. But the diaphragma palsy is not complication, it's the side effects. You always keep in your mind, use low volume of local anesthetic.
Okay. Thank you, Professor Mario. And there is another question for you from Andrea Viola. Thanks a lot for your sharing. I have a question. There is an older patient, age over to 70 years old, who are getting a radial bone fracture and receiving the surgery. In your experience, what kind of block would you be better for him?
Radial?
Radial bone fracture.
Yes.
Radial bone fracture. There is an older patient, yes, an elderly patient with radial bone fracture and recovering the surgery. In your experience, what kind of block would you better for him? But he didn't mention the proximal radial or distal radial. So what do you think, Professor Mario?
It's no big deal. The first is depend of patient, depend of their ability of the anesthesiology, depend on surgeon. If you choose only one technique, supraclavicular approach is nice. Infraclavicular approach is very nice. Axillary block is very nice. Or peripheral nerve block. You should block for ischemia, musculocutaneous nerve, radial nerve for the tricep, ischemia, and pain of the bone. And the posterior cutaneous nerve is from radial nerves, medial nerve, and ulnar nerve. All blocks upper to the above from the elbow. It depends on the patient. It depends on your combination for regional anesthesia plus general anesthesia, regional anesthesia plus sedation. In my daily practice, I perform infraclavicular block or supra.
Mm-hmm. So
Thank you.
I think sometimes in China, some doctors would choose axillary block. So they will prefer that approach. So because they think just one block site can block 3 different nerves. That's very efficient, very time saving thing, and probably also very safe. So they would choose that approach. But I think you mentioned that supraclavicular block would be better, or is your best choice. So how do you compare those 2 approaches?
In my opinion, when you practice axillary nerve is the safe. Why is the safe? Because the people are afraid to the pleural puncture.
Mm-hmm.
For the reason the majority of anesthesiologists make or perform axillary nerve block.
Yeah,
it's very easy, but the people don't thinking in the local anesthetic toxicity, because you have 2. Sometimes I saw 3 and 4 vein in the axillary area.
mm-hmm.
It's not clean. It's not clean area. It's not clean area. And you should block medial nerve, ulnar nerve,
Mm-hmm.
radial nerve, musculocutaneous nerve, medial cutaneous forearm, and medial cutaneous of arm. 6 nerves in the axilla. Minimum 4 needle insertion to block different blood.
Yeah.
And for the reason I prefer only needle insertion, or 2 in supra, on infra, only 1. Mm-hmm. The pleura is so far, really, is so far. Now I'm writing a new approach for infraclavicular approach. Is one of my colleagues in Chile say, it's speaking in English, it's 1 block to avoid pleural puncture. Mm-hmm. It's pleurophobic. Name it, my friend. It's very nice because it's in plane or out of plane from caudal to cranial. It's very easy.
Yeah.
And only 1 insertion, 20 cc of solution, the block is done.
Yeah, perfect.
Another question to Professor Maria. Do you combining neurostimulation with the ultrasonography or not?
Always. Always.
Always.
Always. In all of my block, I have a lot of resident. And always use neurostimulation plus ultrasound. Always. Always. I have it, my neurostimulation in near to my ultrasound, and always use it.
Why? So is it much safer?
Absolutely, because thinking in your car. Mm-hmm. Nobody can drive any car from 1950. Mm-hmm. You have electric car, have airbags, driver, nice. Well, in my opinion, it's personal opinion. You always use neurostimulation plus ultrasound for safe. It really, I have 15 years practice dissection and ultrasound and real anesthesia. I have a lot of ability, but in my opinion, it's better because I combine and instead inject local anesthetic, increase the electricity. I have a rough modification procedures because when I have in a private hospital, when I put back my needle, the surgery start to operation. And for the reason, I need to be very accordant with my techniques.
Yeah, understood. So what you said, I think I totally agree. But the current situation in China is a little bit different. You know, there are two different schools of using stimulator. The one is that they think stimulator is old-fashioned. I mean, yeah, they say that is last century techniques that we have ultrasound. You know, we can see anything. We can see anatomy very clear. So we can ensure the needle tip enhanced, visualized very clearly. How could it be possible for me to just add on another, tools beside me and need another person to operate for me? So that's very, very time consuming, very time costing thing for them. Of course, definitely they agree that the stimulator could enhance the safety of the operation. But the only thing they care about is the speed of the injection. They want to end it as soon as possible. That's all. Because in China, huge amount of people is waiting for the anesthesia. Like one doctor in the surgery room, they can receive like as much as like 30%. So they just do, one by one in a total day. So it's quite a large quantity for them. It's heavy burden for them. So they sometimes choose the best time saving things for them. And another school I heard from professors in a hospital near Shenzhen. He is in an orthopedic hospital. He do just orthopedic surgeries in anesthesia. So he thinks that they ensure that everybody in his department to use stimulator to enhance the safety. And he thinks is a better trade-off of the stimulator combined with the time, although it's time consuming, but it ensures much safer for the patient. That's what he thinks. So there are two different kind of schools. I think you probably you're right. Yes, I can totally understand.
Yeah, I think is the neurostimulation is old-fashioned. It's like a four. Tesla is the iPad with wheels.
Oh, yeah.
And I think why not combination? All patient is not easy. If you have an easy patient, well, nice. But sometimes you can use it to clarify your anatomy. Sometimes the anatomy is not good enough. And in this kind of patient, you can use it, but you should teach to the resident what is, because one question to send to launch to the chat. What do you planning and what do you see the bracket vaccine? And if you don't teach to the audience how to identify the lesion of the ulnar nerve or the medial nerve or the radial nerve, how can you teach us? if you don't teach neurostimulation. And is the patient, the last week I worked with one hand surgery, is one of my friends, and said me, Mario, don't block the ulnar nerve. I am only make a cut in the medial nerve area. I say, are you sure? Yes, I'm sure. When the doctor cuts the skin, the patient suffer pain. And I say, really, it's not medial nerve, it's the anastomosis between ulnar and medial nerve. And for the reason, it's the safe combination, the neurostimulation plus ultrasound. I practiced several blocks for years, several. But sometimes in one situation, they say, I'm not, it's not good. I need it, use it. I share with the audience one of them. If you share, let me share the screen.
Okay.
Look at this. I would like to share one of my video making neurostimulation. It's in Spanish, okay? This is a muscular cutaneous approach. Do you see it? Can you see it?
Yeah.
This is muscular cutaneous approach. Sorry. This is muscular cutaneous approach. It's the last week. Radial nerve.
Esta es estimulación del nervio radial.
This is radial nerve. Proximally. It's important to know the neurostimulation because if the lesion is not the same in the tricep, in the humerus, in the left part of the arm of the frozen compartment is important. This is ulnar.
I saw you like out of plan techniques. So
Out of plane, out of plane. It depends. This patient is diabetes.
okay. Some person would like prefer the implant always. They don't like
Out of plane. It depends. I teach to my resident different approaches. This is 5 minutes after surgery, after block. Okay, this is my daily practice.
Excellent.
Okay.
Great.
Yeah, very impressive.
And this is for the reason you should learn anatomy. This is the dissection of the cadaver to dissect the superficial radial artery and branch. Okay, thank you.
Thank you.
No.
Professor,
Sorry.
Please.
Look at this.
Okay.
In this technique, I combine both neurostimulation and ultrasound. And look at this. One part of the needle is near to the nerves and the other part is into the vessels. I have it.
Yeah.
Neurostimulation, but this is blood. I practice several blood per years. 6, 8 per day. It's a lot of.
Yeah.
This is blood. Sorry.
Okay, great.
Do you have a pressure monitoring gadget while you are performing, and do you use pressure monitoring gadget?
I use it. I use it most of the university have it.
What do you think about?
For teaching is nice. But
Okay.
you see the tip of the needle, you have nerve stimulation, you get the nerve with hydrodissection. Really, for me, I use it. I'm teaching for my resident. But for me, the combination of nerve stimulation as ultrasound is good. I don't necessarily this one.
Good.
Could you give me to share and teach one video, because one of the colleagues asked me regarding. Look at this. This patient suffered tracheostomy.
Mire, es un paciente
This is in Spanish. This is patient.
de cuello,
Look at this.
al cual, si vamos a hacer un bloqueo interescalénico, tenemos que tener cuidado.
Shoulder surgery.
Ver la movilidad de las cuerdas, porque podemos tener una disfunción de las cuerdas si tenemos extensión del anestésico local hacia la parte medial y que bloqueamos el laringio recurrente.
Shoulder surgery.
Can I see the video now, Professor?
Wait a minute. Wait a minute. Wait.
Hay que tener cuidado.
Okay.
Porque podemos.
Shoulder surgery and clavicle fractures. These patients have vocal cord palsy after surgery because the recurrent laryngeal nerve damage. In this patient, you don't perform interscalene block. In this patient, I use for clavicle fractures, periclavicular injection, and for shoulder, upper trunk. Sedation plus reunion anesthesia. Look, this is displaying.
Una disfunción de las cuerdas.
They have a dysfunction of the vocal cord. Listen the voice of the patient.
Y si tenemos cirugía de clavícula como es ahora, tampoco podemos hacer un bloqueo interescaleno.
It's in Spanish, sorry.
Si vamos a hacer un bloqueo del pecho cervical superficial, hay que tener cuidado.
If you practice superficial cervical plexus, if you inject posterior to the deep layer, probably the phrenic nerve get it, or reach.
Sure.
And it is for the reason, this is, all patient is different. All patient is different. I record all.
Yeah.
You can
record it and you combine it in the education material. So every time you can get it out and say, you see, this is a very special case, and somebody will say, oh, you are fantastic because you recorded everything.
I have 20 gigabytes of video and image.
Yeah, sure, definitely. So for education, I think is a fantastic way to do that. Great. So I think today, due to time limitation, I think we have to say goodbye to all of the audience, and let's say is the ending to this this time's webinar. So I would like to appreciate your great lectures of both Professor Mario Fajardo and Professor Tolga Ergönenç. So thank you so much for engaging in this webinar. And I think we're gonna have next time our webinar again in the coming few weeks, I think, probably. So thank you so much. As you know, we have currently over 1,000 views in Chinese platform. You know, they are very interested in our lectures. You can see that this is our platform. We are broadcasting in China domestically. So it's different platform.
Oh, really?
Yes. It's already over 1,000 views. So it's quite
really?
Yes, 1,000, more than 1,000. You know, in China, we have probably like 180,000 anesthesiologists, I think.
Yes.
Yeah, because China is a huge country. We have 1.4 billion people in here. So, but for doctors who know ultrasound, it's not so common, I think. So we have to promote these techniques. We have to promote this technology to all of the anesthesiologists with passionate heart, like what you did. Okay.
Really easy.
Excellent.
Ultrasound and real anesthesia is easy, but it's easy if you know to be easy.
Yeah, but with better education, you can say it is easy. But you know, without education, nobody can do that. You know. Yeah, I agree.
Because easy mean not zero complication. It's different. Yes, we are always say this is easy. You can do, but it doesn't mean zero complication. When you are using ultrasound, when you are combining neurostimulation, when you're combining with the pressure monitoring, there is no zero complication. If you're doing something to your patient, you need to know there is no zero complication.
Yeah, sure.
You have to get your education.
Yeah. So thank you so much. And also I would like
Thank you so much.
Yeah, I would like to express my gratitude to all of the audience who are joining, staying with us today. So if you want to get more information about Wisonic new webinars, please follow Wisonic in Facebook, LinkedIn, Twitter, and other social media platforms. So thank you all and see you soon. I think we have to say goodbye.
Goodbye. Thank you so much for all audience and Professor Mario and Wisonic.
Goodbye, Professor Mario.
Bye. See you
Have a
the
good
next
day.
time.
Have a good night.
Nice day.
Have a good day.